I think with the newer generation DCBs, first you have less distal embolization, so there's less paclitaxel to the wound.
Hello, I'm Marta Lobato, vascular surgeon from Spain. We are at PVI 2025, and today we have with us Dr. Tze Tec Chong, and he is the head of the vascular surgery department in Singapore General Hospital. So welcome to PVI.
Thank you.
And we are talking today about the Ranger DCB trial. So my first question for you is, what distinguishes the Ranger DCB from other DCB technologies on the market?
Great, thanks Marta for the question. I think DCBs are used extensively in the SFA. For BTK segment, it's less used, and in many countries, they're not reimbursable. In Singapore, fortunately, we don't have that restriction. And the Ranger being a newer generation DCB with low dose coating, it allows for inhibition of the restenosis, which I've shown in the data that I'm going to present just a bit later on. A high proportion of diabetics and a high proportion of renal failure patients, it still has a good amputation-free survival in Rutherford 5 and 6 patients. So I think it's a good adjunct for treatment for BTK disease. Yeah.
So in your opinion, what are the most clinically meaningful outcomes demonstrated in the Ranger DCB trial?
So we have about 100 arteries that are treated with 12-month follow-up. And I think the most important thing is that for treatment of Rutherford 5 and 6 disease is wound healing, because it's not claudicants. So wound healing rates is most important. So you got to get enough patency, 3 months or a bit longer, to allow for the wound to heal. So I guess wound healing would be the best outcome measure. So amputation-free survival, wound healing, I think...
Totally agree with you that in CLTI patients, wound healing is our purpose. So do you have any concerns about paclitaxel and its cytotoxic effect in the wounds?
That's a great question. I think that there's always a concern because paclitaxel, as you mentioned, has inhibition of wound healing. But I think with the newer generation DCBs, first you have less distal embolization, so there's less paclitaxel to the wound. And also the coating concentration is not as high as the first generation products. So I think that there's less of that concern. And we see that in the PK studies in the blood, for example, well within the safety range for this particular application.
Do you think were there specific subgroups in the trial showing better performance?
You know, it's only 100 total arteries treated, and we try to look at subsegmenting them into those with renal failure and those with diabetes. And those with renal failure, as we know, are more challenging than just the diabetics alone. I think in this group of patients where there are about 88% diabetics and 36% renal failure, we just want to see a good result. We're not looking for the best performers because this challenging group of patients to start with. So I think that's the message.
So how do you interpret the safety profile in this trial?
This trial wasn't specifically made with the safety in mind. However, we have 30-day mortality and any kind of device malfunction, which we didn't have any. So I think that gives us some confidence that the safety is quite good for the Ranger DCB.
Okay, and now let's go for a hot topic. I have to make this question. Do the SWEDEPAD outcomes affect your device selection or patient consents nowadays regarding paclitaxel-coated drug-coated balloons?
I guess what you're referring to is the SWEDEPAD did not have any benefit for the paclitaxel-based DCBs.
Yeah.
In terms of patency. I do think that obviously that's the result for this large registry, and we have to take that into concern. We see in our population that the patency is maintained 6 months and 12 months in quite a large proportion of these patients with comorbidities of diabetes and end-stage renal failure. So I think that for our population, it seemed to work, but this is not a randomized trial, it's a registry. So we have to wait for a randomized trial to actually show efficacy. But this is just a modest sample to show that we can use this in the BTK segment without much concern for safety and with quite good benefit for CLTI, Rutherford 5 and 6 patients.
Okay. And what remaining gap in evidence would like to see future studies regarding DCB therapy?
I think there are, in my recollection, about 6 BTK DCB RCTs, and they have not shown benefit. So I think it would require something like that, or at least a very nicely matched cohort control study for this indication to get through the regulatory authorities. So that's probably something that we've got to carefully design with the companies moving forward.
Okay, and just the last question. What advice would you give to the physician reluctant to adopt DCBs due to all these controversies with paclitaxel and so on?
I think first is comfort with the device, whichever DCB you're comfortable with, the characteristics of the DCB, the amount of slow flow phenomenon. For example, if your outflow crural vessels are not as good, I think all that is of concern. Naturally, regulatory, whether or not you can use the DCB, whether it's paid for in your health system or not, is obviously of top concern as well. And then on top of that, you decide whether you think a longer patency afforded by the paclitaxel DCB would be a possibility, and if so, consideration for that DCB should be used.
Okay, so thank you very much for this nice conversation and for all these advices. Thank you so much.
Thank you very much.